Now glaucoma. So in this lecture we will only focus on the congenital glaucoma, especially primary infantile glaucoma. Okay. So what is glaucoma? Glaucoma, it is a progressive optic neuropathy characterized by optic disc changes and visual field defects. Okay. This is the disorder of the optic nerve, which is characterized by optic disc changes and associated visual field defects. Remember, it can occur with any cause, but the most common cause of this optic neuropathy, this is the increased intraocular pressure. Okay, the increased intraocular pressure is the most common cause. That's why we can also define as that the progressive optic neuropathy with disc changes and associated field defects due to the increased intraocular pressure. Okay, because of its most common cause. Now, pathogenesis, we have two theories for pathogenesis, the mechanical theory and ischemic theory. Mechanical theory suggests that when this intraocular pressure elevates, what is happening? It will cause pressure on this posterior segment of the eye. And this pressure, especially at the lamina cribrosa. Lamina cribrosa is the part, is a sieve-like structure through which this optic nerve passes and is relatively a narrow part. Okay. So that's why this pressure will be so much at the lamina cribrosa. And this increased pressure will cause two problems. First of all, it will disrupt the blood vessels. Okay, so it will cause ischemia and vascular insufficiency. And the second one is that it will compress the axons. Okay, so axonal flow will also be disturbed. So remember, for the normal retinal ganglions, for its maintenance, these ganglions need growth factors which comes from the brain, okay, through this optic nerve to these ganglions called the neurotropin growth factors. Okay, so for the normal maintenance and function, they needs these growth factors. When there is this pressure, this elevated pressure and ischemia, these growth factors now they are disrupted because of the increased pressure and ischemia. These growth factors cannot be reached to the ganglions. What will happen? These ganglions will degenerate through apoptosis because of the insufficiency and because of the deficiency of the growth factors. These ganglions will degenerate, and these ganglions fibers, as we know that the fibers of these ganglions, they come and they form this optic disc, okay, the optic nerve head. So when there is the dropout of these ganglions, these nerve fibers will also degenerate and they will cause characteristic changes in this optic disc, and due to the dropout of these ganglions and nerves, there will also be visual field defects. Okay, so this is the mechanical theory. And the ischemic theory is present in the mechanical theory, as the ischemic theory suggested due to any cause, due to Raynaud phenomena, due to hypotension, when there is the vascular insufficiency, means ischemia at this optic disc region. Again, the neurotropin's growth factors, it will be disturbed. So the neurotropin growth factors cannot reach to the ganglions due to the ischemia and will cause these visual field defects and optic disc changes. Okay, so this is the ischemic theory. Now come to the congenital glaucomas. Congenital glaucoma is mainly of three types. It is true congenital glaucoma, which is account for about 40% of glaucomas, okay, of the congenital glaucoma. We have juvenile. Remember, true congenital glaucoma, the glaucoma which is present from birth, okay. Then we have juvenile glaucoma, which is the least common cause, and this juvenile glaucoma is only 5% and it appears from 3 to 16 years of age. Okay, the most common type of congenital glaucoma is primary infantile glaucoma, which accounts for 55% cases all over congenital glaucoma. That's why we will only focus on primary infantile glaucoma. Primary infantile glaucoma, it is the increased intraocular pressure due to impaired outflow of the aqueous humor, When the aqueous human outflow is impaired, it will increase the intraocular pressure. This is called primary infantile glaucoma. But remember, a case will be called primary infantile glaucoma if it follows three rules. First of all, it should have trabeculodysgenesis. Trabeculodysgenesis means that there should be the maldevelopment of trabecular meshwork. Okay, so there should be the maldevelopment of trabecular meshwork. There should be the developmental anomaly. The second is there should be no other ocular disease or surrounding ocular problems or pathologies. Okay, so without any other ocular disorder. And the third rule is that the intraocular pressure should elevate within first year of birth. Okay, so after birth, within the first year of birth, the intraocular pressure should elevate. So these are the three rules: the trabeculodysgenesis, no other disease, and IUP elevation within first year. When these rules are followed, it will be called primary infantile glaucoma. Now, etiology and epidemiology. As it is caused by trabeculodysgenesis, means there is the developmental anomaly in the trabecular meshwork. Okay, it is most commonly encountered in males, and it is in 70% case it is a bilateral condition. Okay, the IUP elevation pattern is that in 40% cases the intraocular pressure elevates at birth. Okay, it is elevated at birth. In 80% cases the intraocular pressure elevates at 6 months of birth, and in 90% cases or in primary infantile glaucoma the intraocular pressure elevates within the first year of birth. Okay, in 90% cases. Now, pathogenesis. What is the problem with the trabecular meshwork? There is one thing you should remember. They are saying that if I zoom this trabecular meshwork, okay, if I zoomed it, this is the trabecular meshwork, they are saying that it is a universal agreement that there is the developmental problem with this trabecular meshwork. But what type of anomaly is present, it is under debate. Why? Because there are several theories. These theories are, one theory suggested there may be a membrane. A membrane may be present in front of this trabecular meshwork. Okay, a membrane may be present, and they named it Barton's membrane. Okay, another theory suggested there may be a cellular membrane. Okay, so there may be a cellular membrane in front of this trabecular meshwork. Another theory suggested there may be the developmental problem with this trabecular meshwork itself. Okay, and the next suggested there may be the thickening, the abnormal thickening of this juxtacanalicular part of the trabecular meshwork. And the last suggested there may be the developmental problem in this Schlemm canal itself. So these are the different theories which are suggesting this developmental abnormality. But what is the exact abnormality? It is now under research and debate. So this is the pathogenesis. But remember, the main problem is the developmental anomaly in the trabecular meshwork. Okay, which is present at the interior chamber angle. Now the clinical features. How will the parents present their children to us? How will they will be presented? Remember, this is the increased intraocular pressure. Okay, so the patient will present to us with corneal edema. Okay, because of the increased intraocular pressure, the endothelium will decompensate and it will cause edema. Okay, so it will cause corneal edema, and with the corneal edema with its associated symptoms like the pain, photophobia, blurred vision, lacrimation, watery discharge, etc. Okay, and there will be ophthalmos. Ophthalmos means when the eyeball enlarges abnormally. As we noted that the ocular development is completed at 3 years of age. So when there is any problem, for example, when the intraocular pressure increases at this period, it will cause the ocular length to increase. The ocular bulb will be increases because of this intraocular pressure. This is called ophthalmos. And due to this increased intraocular pressure, the corneal diameter will also enlarges. This is the corneal diameter is normally at birth. The corneal diameter, the horizontal corneal diameter, it is about 10 millimeter at birth. Okay. So when the corneal diameter increases from this 10 millimeter, it is a suspicious for primary infantile glaucoma. So we will have ophthalmos, enlarged corneal diameter more than 10 millimeter. Okay, the horizontal diameter will be more than 10 millimeter. We will have, because of this decompensation of the endothelium, the descendant membrane will breaks down, and when this descendant membrane breaks, they heal in a special pattern like in a curvy linear lines. Okay, so the descendant membrane healing in a curvy linear lines pattern, this is called half stria. Okay, and we will have myopia because of this increased intraocular pressure. As we know that the eyeball is abnormally enlarged. So because of this enlargement, there will be myopia. The light rays cannot be focused on the retina because of the enlarged eyeball. This is called axial myopia. And because of this enlarged eyeball, we can have the rupture of these zonules. And this rupture of zonules will cause ectopia lentis and associated iridodonesis. Iridodonesis means when the eyeballs move, the iris also moves with it. This is called iridodonesis. With the movement of eyeball, the iris also moves. Okay. So these are the clinical features with which the patient will present to us. Okay. Now, how can we diagnose the condition? The condition can be diagnosed with gonioscopy. Gonioscopy is the evaluation, is the analysis of this trabecular meshwork through gonio lens. Okay, we will discuss these different procedure for the glaucoma in details in another separate lecture. Okay, so remember, this is the evaluation of the anterior chamber angle. And the treatment. The treatment for the primary infantile glaucoma, the treatment is satisfactory treatment is surgery. Okay, but remember, before surgery we have to indicate drug treatment. Why? Because when there is the edema of the cornea, so the diagnosis cannot be made. Okay, so for the tail surgery, for the diagnosis and for the relief, we should indicate drug treatment. Okay, so the drugs which we are using for the primary infantile glaucoma, they includes prostaglandin analogs. Okay, prostaglandin analogs such as latanoprost, bimetoprost. Okay, and then we can use beta blockers such as can be used such as timolol, leobonolol. Okay. After beta blockers, we can also use carbonic anhydrase inhibitors. So carbonic anhydrase inhibitors can be used. Okay, anhydrase inhibitors can be used. Remember, we cannot use alpha 2 agonist in children. Why? Alpha 2 agonist, although they are using, we use it for the acquired glaucomas, but in children, alpha 2 agonist can cause severe depression. That's why we do not use alpha 2 agonist in congenital glaucoma. So prostaglandins, beta blockers, carbonic anhydrase inhibitors, and one more drug which is miotic. Miotic drugs, they cause meiosis and they cause pupillary construction. But we do not use miotics. Why? Because miotics are of no use. Miotics increase the outflow through the trabecular meshwork, but now there are no trabecular meshwork as it is maldeveloped, so we cannot use miotics. The definitive treatment is surgery. So the first surgery we can indicate, which is the primary treatment of choice. This is goniotomy. Okay, so goniotomy is the primary treatment of choice in primary infantile glaucoma. And goniotomy, what are we doing? We are making an incision, and we are getting an incision in this maldeveloped trabecular meshwork. Okay, so we are getting an incision. Okay, but remember, when the cornea is clear, when there is no edema, so goniotomy is then possible. When there is edema, we cannot do goniotomy, we will do trabeculotomy. In trabeculotomy is this surgical procedure and diagnosis. I told you before that these will be discussed in detail in separate lectures because they are important. Okay, I am only giving an overview. So in trabeculotomy, what are we doing? In trabeculotomy, we are making an incision. We are incising the sclera, okay, and we are entering into the interior chamber, okay, and we will remove through the deep scleral flap. We will remove the trabecular meshwork like this, okay. So we will remove the trabecular meshwork, and we will directly connect this interior chamber with the underlying deep incised sclera, okay. And if we do not, if trabeculotomy is not possible, if it fails, then we indicate another procedure which is called trabeculectomy. Trabeculectomy is a procedure, trabeculectomy, in which we are making a filtration path between the subconjunctival space in the interior chamber. Okay, so interior chamber is directly connected to the subconjunctival or subtenon space, and at last, if all this procedure fails, then we indicate another procedure called artificial drainage devices. Artificial drainage devices can be kept in the sclera. Okay, so artificial drainage devices for the glaucoma. The last treatment, if we do not have any alternate treatment, then what will we do? We will just destroy these ciliary processes. If you do not have any alternate to treat this congenital glaucoma, if all the treatment, if the drug, if these surgeries, they fails, then we do not live with anything. So we will destroy these ciliary processes with laser. For example, diode laser, through a process called diode laser cycloablation. Okay, so this was about the primary infantile glaucoma.